to the second presentation in our series on public health. The objective is to first raise awareness of public health issues, and second, to recognize the importance of health initiatives in our community. My co-moderator, Marianne Shavlin, and I, Raina Lari, are both board members of the League of Women Voters of the Bay Area, and we are delighted to have you with us today. Marianne, would you like to welcome?
I'd like to welcome you on behalf of the League of Women Voters of the Bay Area, and to really share our excitement about how our speakers are going to share with us about chronic diseases, long COVID, and a lot of other great information. What I'd like to, just a little housekeeping, you will be able to enter questions in the chat throughout the presentations, and we will try and get to all the questions through at the end of the presentations from the 4 presenters today. And now I'm going, but in the meantime, please stay on mute, that you limit any distractions. And now I'm going to turn it back over to Raina to introduce our distinguished speakers.
Thank you, Marianne. So our topic today is infection-associated chronic conditions. A sizable percentage of patients suffering from post-infectious diseases like long COVID and tick-borne diseases continue to suffer from debilitating symptoms long after the infection is supposed to be over. These chronic conditions have a devastating impact on the affected individuals and their families. Our speakers today will discuss the path-breaking work being done to understand, address, and manage these very challenging conditions. Our speakers today are Wendy Adams from the Bay Area Lyme Foundation. She will speak about their pioneering work on advocacy on Lyme and tick-borne diseases to make them easy to diagnose and simple to cure. Dr. Carla Kuon will speak about her work and experience with patients at the long COVID clinic at UCSF. The clinic is one of the very few in this area. She has also authored a book on the condition. Dr. Alison Cohen and Lisa McCorkle will jointly present on their work with the Patient-Led Research Collaborative, which aims to facilitate patient-led and patient-involved research, showing us the potential of community citizen science. So we will start with Wendy Adams, who will talk about Lyme and tick-borne disease. Thank you.
And Wendy, you're on mute right now.
Thank you. Okay. Can everybody see my screen?
Yes.
Excellent. Thank you. Well, thank you so much to the Bay Area League of Women Voters and Raina, Larry, and Marianne for inviting me. It's our pleasure to be with you here today. And we'll be talking about Lyme disease and chronic Lyme disease, and happy to answer questions as well. So today we'll talk about our foundation a little bit. We'll talk about the ticks that are located in California and across the country and the infections that they carry. We'll talk specifically about Lyme disease because that is the most prevalent infectious vector-borne disease in the country. And also then we'll talk about chronic/persistent Lyme disease. So a little bit about the foundation. We were founded in 2012, and we are the largest public foundation that funds Lyme disease research. We have collaborated with institutions across the country. We've had major tick collection efforts that have gone on to publish really interesting findings. We reach more than 2 million children through outdoor education and high-risk sports prevention and awareness programs. We run the largest biobank of patient samples to facilitate diagnostics researchers research into better diagnostics and therapeutics. We have something called the Emerging Leader Award, which supports early career scientists to help them establish their careers in tick-borne disease research. And we've supported dozens of scientific studies published in leading journals. So there are many hard tick-borne diseases in the US, and these are hard tick diseases. There are also soft ticks, but we won't be covering them today, even though they do appear in California. So on the left, the Ixodes species of tick is the most common biting tick across the country. In California, we have something called the Western black-legged tick. And as you look at the left, you'll see the starred pathogens are present in California. Obviously, B. burgdorferi is Lyme disease. That is the biggest, but there are several others, and it's really important to remember that if you are presenting with a tick bite, that you make sure you get tested for these other infections. Amblyoma is the Lone Star tick that you might have heard of. It vectors pathogens, but also it can cause a hypersensitivity to a specific sugar, and that in turn leads to an allergic syndrome to mammalian meat, and not just ingesting meat or dairy products, but also sometimes reacting to those products which are in like cosmetics and medical supplies. It's becoming a very big issue. The dermacenter tick is also in California. It can carry and transmit spotted fever rickettsiosis. So if you've heard of Rocky Mountain spotted fever, this is the tick that one of the ticks that transmits that. And then rhipicephalus is a tick that's across the country and vectors different pathogens. So what is Lyme disease? Well, it's an infection caused by Borrelia burgdorferi. It's the most common vector transmitted disease in the Northern Hemisphere. And importantly, it can be transmissible in utero. And this is not surprising because syphilis is its cousin, leptospira is its cousin. These are known to be transmissible in pregnancy. And so this is something to be very aware of. There are about 500,000 cases a year in the US. It's also endemic in Europe and over parts of Asia. And somewhere from 10 to 30%, depending on the study, are still symptomatic after a short treatment. In California, our temperate climate means that it can transmit year-round. And so this is also something to consider, is that it can be, the ticks are active actually right now with all this rain. They come out, they like the moisture. So you can get a tick-borne infection anytime during the year. And if you work or recreate outdoors, like so many of us do, you're particularly at risk. And Lyme disease is frequently misdiagnosed, especially outside the Northeast and in the emergency room where it often presents. So this is a video of the pathogen, the spirochete, and this is spiral shaped, hence the name spirochete. It can go forward and backward. It drills through tissues, including blood vessels and heart tissue and the brain and the joints. And so this is one reason it's so hard to eradicate. It can go and hide in places. It very easily travels around the body, and it likes to avoid places where there are things like antibiotics and oxygen. So ticks are very difficult to detect. So they're easily missed with the naked eye. They often seek out hidden areas that are moist, like the groin, scalp, and skin folds. They inject anesthetics, so you don't feel the bite. And only about 30% of adults diagnosed with Lyme recall a tick or a bite, and that's even less in children. And this is problematic because doctors oftentimes won't make the diagnosis without knowing that somebody has come in with a tick or a bite, but that happens in a minority of cases. And this is not just an East Coast disease. So B. burgdorferi, the Lyme spirochete, has been found in 3/4 of California counties. And the tick itself has been found in 55 of 58 counties. And so this is important from a counting perspective. And here's a little case study. In California in 2017, 156 cases were reported to the California Department of Public Health. But in that same year, Quest Diagnostics reported 500 cases. And that was only Quest, which is only one of the reference labs, of course, that can diagnose Lyme. But California had the 5th highest Lyme insurance claims in the country. for that same year. So, and this is the numbers are in the vector-borne disease annual report, but you can see the problem that it's a very small minority of cases that are actually reported. This is a problem because doctors often see those and say, oh, there's not really any Lyme disease in California, but it's a gross understatement. So for signs of Lyme, you really want to think about potentially a rash. These can be round, oval, triangular, or irregular shaped. It's a very heterogeneous rash. It's not normally itchy or painful, but it can be warm, and it's often misdiagnosed as a spider bite or cellulitis. And as you see on the left-hand side, the bullseye rash is often diagnosed, but this is a minority of the rashes that present. More commonly, you see on the right-hand side that it doesn't have central clearing, it doesn't look like a target, and so this is why doctors miss it. In addition, this presents very differently in people of color. And there's a new study out that showed that Black people get diagnosed at a later stage because the rashes are missed. So this is something that is being looked at it and really has major ramifications for people of color. So the most common symptoms early is flu-like symptoms or a rash. Oftentimes it's really a headache. It can be a differentiator between a regular virus or the flu, but a headache is very prominent. After a few weeks to a few months, you might see multiple rashes, and you might see carditis, which is an inflammatory condition of the heart. This is important because if you have any heart-related symptoms and you think you might have been bitten by a tick, you need to get to the ER. This can be rapidly fatal, and so you need to go to the ER, tell them you think you've been bitten by a tick, and you want to make sure that they are monitoring your heart and get on antibiotics immediately. It also can infect the nerves and infect the meninges. In late disseminated Lyme, after 3 months, arthritis is often presents in like a knee or maybe multiple joints, and then additional neurological symptoms. Now, the problem is, if you look at these numbers, these are the sensitivity numbers in these different areas. Early acute, for people who have a rash, we know they have Lyme disease. The rash is, the test is only 30% sensitive. That's obviously not a very accurate test. As the infection goes on, the infection gets worse, but the test gets better. However, in late disseminated Lyme, it's 100% in arthritis, or maybe 95 to 100%. But if you have a neurological infection, it can be usually more like 70% accurate. So these are still not perfect tests that are used clinically. And if you look here, these are the multiple different symptoms that a patient can present with, both in pre-treated or pre-antibiotic treatment and also in persistently ill patients. So you can see it can manifest many different ways. It can be very confusing to clinicians to try and put all these together and see a Lyme disease case. So the problem with testing is that if you start on the left-hand side, you could have 100 people with Lyme disease, but only 50% have a rash or see a tick. And only 50% of those go to see a healthcare provider, and current testing misses 60% of positives. So you then have 10 out of that original 100 who are then reported to the public health authorities. So moving to persistent Lyme, post-treatment Lyme, what is it? What is the name, and what does this mean? I know there can be a lot of confusion around this, and it's probably the same with these other infection-associated chronic illnesses. Post-treatment Lyme disease syndrome is a research definition only. It's not supposed to be used to diagnose patients. You are required to have a rash or a positive test, and to meet that definition and then be symptomatic for 6 months. And so that is a very restrictive definition, and many people don't meet that because they were misdiagnosed, because they didn't have a positive test. That's why they go on to need persistent treatment. They didn't have the positive test. And chronic or persistent Lyme disease, which is what has been used by a government report that was given to Congress, it requires a diagnosis of an initial Lyme infection, But supportive testing is not required. And this is important because many people do not test positive on that test for many different reasons. And so on the right, you see that the chronic persistent Lyme disease population is much bigger than just the post-treatment Lyme disease syndrome. And now we're starting to move away from the syndrome and calling it post-treatment. It really should be post-initial treatment. We don't know whether these people are cured of their infection. And so how many people are we talking about here? Well, as you see in the graph, as the case numbers go up, of course, so too the new cases of persistent Lyme disease. Our current estimate is about 2 million patients with persistent and chronic Lyme, and that's obviously a large number. Funding is desperately needed in this area. As you can see, these are 3 vector-associated or vector-transmitted illnesses. Lyme disease only receives about $100 a patient for every new patient diagnosed, where West Nile receives about $20,000 a patient, and malaria is about $146,000. Now, obviously, malaria has very few domestic cases, although more recently. Most of that funding goes to ex-US, but we're talking about a lot of money and very few US cases. So chronic disease really costs a lot for everybody. It's not just for patients. And what you see is that the early costs, about $2,000, a little more. You know, if you catch it early, you can treat it, and in most cases, you get better, and the costs stop. You don't have productivity loss. And in late and chronic Lyme disease, what you see is that the cost goes way up, and that the productivity loss is pretty severe. This comes from My Lyme Data, which is a very well done patient registry by LymeDisease.org. They have information on the website if you're looking for more information. So in Lyme disease, there are major issues. The first is that the diagnostics are insensitive. When does someone have it? When can we pick up the test? Can we pick it up in time for people to actually get better from treatment? And then we don't know when someone is cured. The tests that we have cannot determine when a patient does not have infection anymore and might be ill persistently because of different causes. So we can't say if anybody who's been treated with antibiotics has been sufficiently treated or adequately treated. And this is a major issue for diagnostics. There are confounding factors. So people can contract more than one of these diseases at a time or from subsequent tick bites. It's not uncommon for persistently ill patients to have more than one infection. As a matter of fact, it's the majority of them. And that makes treatment more difficult. It makes diagnosis more difficult. Some people have background autoimmune issues that can also be confounding from a treatment perspective. And patients just have different genetic backgrounds. And whether or not that is playing an issue, we know, for example, that you're more likely to get arthritis if you have a particular gene allele. So, but we're at the infancy of really understanding that. And then, you know, treatment doesn't always restore health. What is the cause of these persistent symptoms? And there are 3 really hypotheses. Persistent infection is one. And there's data to support that, both in patients and in animal models and in vitro. Autoimmunity, do people's immune systems mischaracterize or misassociate a protein and think it's Lyme disease when it's not? It's actually a self-protein, and then go on to mount an immune response against that self-protein. There's data to say that some people are ill because of that reason. And then a central sensitization, which is that your nervous system is constantly primed because it's been fighting these diseases, and therefore it doesn't know how to calm down, and that is what's causing symptoms. And it could be all 3 in the same patient. And right now we don't know which patients are sick for what reasons. So the risk factors for chronic persistent Lyme, the first is delayed diagnosis. And this is consistent, that the longer it takes you to be diagnosed with Lyme, the more likely you are to develop persistent symptoms. The second is the wrong diagnosis. As you saw, cellulitis is common. People are often diagnosed with something called Bell's palsy. And this causes an additional problem of the wrong drugs. And the wrong drugs are important because you might get steroids for Bell's palsy, which is the wrong thing to give somebody who has an infection. And you might get the wrong antibiotics, which again codes for more likely to develop chronic symptoms. So these infection-associated chronic illnesses are overlapping and interrelated. And I think that is something that we are just starting to understand. And one thing this movement has been so helpful with is getting people to talk together. The tragedy of COVID and long COVID is helping us understand the mechanisms behind what might be happening in Lyme disease and what might be happening in ME/CFS and what might be happening in other infection-associated chronic illnesses like dysautonomia, like fibromyalgia, like potentially multiple sclerosis. And this is helpful because we have 20 million patients just with the ones on the screen right now. This is a large and growing issue. Certainly, it existed before long COVID, but long COVID has exposed the fact that very little was known about these and very, very little money was spent on studying these diseases. So what do we need now? Well, this is, again, a growing issue. We need, for Lyme disease, better education on early Lyme because so many patients are misdiagnosed, and that puts them at greater risk of developing long-term symptoms. Doctors often can't recognize the rash, or they can't put together the constellation of symptoms, and therefore that we need better medical education for that particular presentation. We need more research funding for the chronically ill patients, and that means we need better diagnostics who not only can diagnose Lyme at the different stages, but also can provide a proof of cure. Because if we know patients are still infected, even after a month or two of antibiotics, then we know we need to treat them with additional antimicrobials and not just other things that might help the immune system downregulate. We still need to attack the pathogen in that case. And we need new treatments. Doxycycline was developed in 1960, but that's still our mainstay treatment. We need more specific medications, and we also need more efficacious medications to address the chronically ill patient population. We also need more active government participation. And on that front, just this week, the US government announced its National Public Health Strategy to prevent and control vector-borne diseases in people. This is based on a pan-government effort, also based on recommendations made to Congress by the Tick-Borne Disease Working Group, which was developed by members who were on a federal advisory committee. This is an important first step, but what we really need is an all-of-government effort to combat these chronic infectious, post-infectious diseases. And with that, I'll say thank you. These are some resources I'll put on the screen, and happy to take questions at the appropriate time.
Thank you so much, Wendy. This was very enlightening and very valuable information. We will take questions at the end of the program. So next we have Dr. Kuon, who will talk to us about long COVID.
Great. Thank you, Raina, so much for inviting me to speak to the Bay Area Women's Voters team. And I really appreciate also collaborating with all the other speakers today. So I'm going to speak a little bit about my clinical practice with long COVID and what I do. And then Alison and Lisa McCorkle will be speaking a little bit about the epidemiology of long COVID. Great. So next slide, please. Next slide. Great. So thank you for that. So in terms of financial disclosures, my only disclosure is I have a book called The Long COVID Solution. I have no other financial disclosures. Next slide. So a lot of the symptoms that cause both fatigue as well as long COVID are related to 4 sort of underlying drivers of symptoms. And one of the biggest ones and the main one is inflammation. Now, most people think of inflammation as being one thing, but inflammation can have many sources and many causes. I list here 5 main sources of inflammation that I see in my clinic, but there are more. So this is not an absolute all-encompassing summary of all types of inflammation. Usually when we think of inflammation, we think of classic inflammation, and this can be measured by labs like interleukin-6 and CRP. And it's the kind of inflammation that you feel like after you have exercised, the soreness in your muscles, the sort of joint pain you may have. It tends to be classic inflammation. When you feel achy, when you are having a fever, that's driven by classic inflammation. But long COVID can also cause histamine-mediated inflammation, and that's driven by mast cells and a few other histamine-producing cells. And we know that long COVID can activate mast cells. Long COVID can also increase autoimmune drive in the body. If people have an underlying autoimmune disease, they are more susceptible to having long COVID. And COVID is also known to sometimes even create brand new autoimmune conditions in the body. Gastrointestinal inflammation can be another source of inflammation, both for the body as well as for the brain, because there's a really very, very well-known brain-gut connection. And then neuroinflammation, a lot of the generalized inflammation that people suffer when they have long COVID can go to the brain and cause neuroinflammation. And then toxins, both in the environment, but disease and infection can cause increased toxins to be released in the body. Absence of nutrients or low nutrients. When we are in the healing state, our body needs even more nutrients to heal or resolve inflammation. So then it becomes critically important to replete nutrients that are low, like vitamin D and zinc. And then stress physiology is another big component of long COVID. Stress physiology can cause neuroinflammation, and then neuroinflammation can cause stress physiology as well. So here's just 5 of the main types of inflammation that I see on a day-to-day basis in my long COVID clinic and in my general clinic. It is key to identify and address all the pathways of inflammation, and that is key to recovery. And you don't need to be limited to one type of inflammation. Some people have 3 or 4 things going on at the same time. So it's important to address all of those together. Next slide. So one back. There we go. Thank you. So I do talk a lot about the anti-inflammatory diet. This is a diet that is rich in anti-inflammatory foods like cruciferous vegetables and rich in antioxidants coming from plant polyphenols, rich in anti-inflammatory foods like that have plenty of omegas, like the fatty fish, the deep cold ocean water fish, and plant omegas. But there are 2 other variations that I prescribe in my clinic based on the patient's history and their laboratory work. Next slide. So the 2 other variations are the low histamine diet. If patients have elevated plasma histamine when I see them, or maybe the plasma histamine is a difficult assay. A lot of things can go wrong. It has to be frozen. So it's great when it's positive. It doesn't always adequately capture a high histamine state. So if the patient just has a lot of histaminic issues, maybe they have asthma, frequent rashes, a lot of migraines, these can all be manifestations of an elevated histamine, then I will put them in a low histamine diet. And here are some foods that are high in histamine. So, preserved foods and processed foods are going to be high in histamine. Leftovers that stay in the fridge for a long time are going to be higher in histamine, and so are fermented foods. So that's one modification. At the bottom of the slide, I have the histamine intolerance group. This is a Swedish working group that has a really nice handout that's free that can help people choose a low histamine diet. Then the other modification on the left is a lectin elimination. Lectins are foods that have some similarities, some biosimilarities to human tissue. And once you have an autoimmunity or you have an autoimmune condition, then these foods can be very problematic. So they're not problematic for most people, but if you're one of the 25% of the people of the world who has an autoimmune disease, these foods become quite problematic. So the mainstay of the lectin-free diet would be eliminating gluten and soy from the diet, as well as a few other lectins, mostly coming from kidney beans and some nightshades. Next slide. One back. Thank you. So some of the workup that I do for my patients when they first come into the clinic is I look for nutrient deficits. This is low-hanging fruit. People need these nutrients to heal, and they feel better once we identify and correct those nutrients. Probably the most common ones are the ones I have highlighted. I see ferritin and vitamin B2 deficiency. B2 is not normally checked by physicians, but vitamin B2 is really important for nerve health as well as for detoxification in the body. And then ferritin is probably the most common deficiency I see in women. Ferritin is better than an iron level. Iron only measures the iron in your blood. Ferritin is a marker of total body iron stores, and most women are bottomed out on their ferritin, which means that that's contributing to a low oxygen state in the body, and it can contribute to exercise intolerance and chronic fatigue. I'm very aggressive about correcting ferritin in all of my female patients and some male patients as well. I also check vitamin D. Vitamin D is the sunlight vitamin. It's really important for resolving inflammation in the body, and many people are zinc deficient as well. Now, the EBV early antigen is not a nutrient deficit, but EBV reactivation is very common in long COVID as well. So I do check this antigen among my panel of labs. And this is something that any primary care physician can order. Unfortunately, the EBV early antigen is only available at Quest labs. It's not available at LabCorp or other labs. Next slide. So after I've corrected patients' nutrient deficits, I will put them on a protocol inspired by this Yannick et al. Article. And I know this is a really busy chart, but it's a very nice graph because it shows you what you can do in everything from preventing COVID, what to do if you have COVID during infection, and the recovery phase, which is the long COVID phase. So I focus on foundational anti-inflammatories that include vitamin D, zinc, vitamin C, vitamin A in some people if they are deficient, quercetin, which has antihistamine properties, fish oil for the omegas, and melatonin for sleep, but also because it can help with neuroinflammation. I place patients on lots of high doses of antioxidants like glutathione or N-acetylcysteine, which is a precursor of glutathione. And then we'll choose some anti-inflammatories like resveratrol or sulforaphane, which comes from cruciferous vegetables or turmeric. Next slide. So talking about inflammation, it's really important to talk about how inflammation affects the brain. Inflammation that impacts the brain can cause higher stress physiology. And this means that the stress physiology on the brain further causes neuroinflammation. And now we have like this looped self-reinforcing cycle of inflammation causing stress and stress causing inflammation. Go back one slide, please. There we go. Thank you. So this inflammation precisely affects the vagal nerve, the vagus, which is cranial nerve number 10. We know that the vagus is negatively impacted by COVID, and it is a regulator of fight or flight responses. And therefore, when the vagus is inflamed, people tend to feel more anxiety, they feel more stressed out, they have more fight or flight, they can't turn it off. So that's really important to break that cycle. Next slide. A little bit about the vagus. The vagus is also known as the wanderer. Vago in Latin is the Latin root of vagabond. So it's the vagabond nerve. And that's because, as you can see here in the picture on the right, it leaves the brain and it kind of navigates through the front and center of the body. And as it does so, it connects to our larynx, our voice box, our heart, our lungs, our diaphragm, multiple organs like the spleen and the liver, and our bowels. So it's a really important nerve that unfortunately becomes dysfunctional after high inflammation is what you get with long COVID. On the left, you can see it's just another picture depicting all of the organ systems that the vagus connects to. The vagus has important anti-inflammatory effects on these organs. Many of the long COVID symptoms, the tachycardia, the shortness of breath, gastrointestinal issues, adrenal issues, are mediated in part by cranial nerve number 10 or the vagus. Next slide. So I talk a lot about vagatonia. You need to tonify your vagus, and I talk about ways to rehab the vagus after severe illness. So because it has outflow branches in the ear, the voice box, the lungs, the diaphragm, and those outflow branches have stretch receptors, one really easy way to activate the vagus and to improve its strength is by doing diaphragmatic breaths. There's a breathing technique called the 4-7-8 that I teach all my patients, and I encourage them to practice it twice a day. That's the first part of vagatonia. Ear acupuncture can be really helpful because there are afferent nerves in the ears, in the concha, the deep part of the ears. Meditation, mindfulness, guided imagery, singing, especially lower tones like can activate the vagus. And then there are other things like transvagal nerve stimulation that has been studied for long COVID. The two devices that have been studied the most are gammaCore and electroCore. And even placing an ice pack to the forehead, there are some receptors there that can have calming effects on the vagus. Next slide. So I encourage patients to adopt the breathing technique twice daily and then do a 10-minute mindfulness practice for rehabbing the vagus. And I tell people when you do a breathing technique, which only takes about a minute, it's like one Pilates push-up for your vagus. And so if you do this consistently, you do end up rehabbing your vagus slowly over time. I do encourage patients to try several things and adopt a 10-minute mindfulness of their choice, however their personality and their belief system supports. There are free apps like Calm, Insight Timer, and Headspace. Guided imagery by Belarus Naprostek costs about only $10 to download one, and then you can listen to that as many times as you'd like. Stasis.live had some free breathing and meditative groups and sessions. They are starting to charge for it now, so that's just one thing to keep in mind. And then, of course, at the Osher Center, we have several free guided imagery meditations that are available for patients. The 4-7-8 breath is free as well. And we have everything from free to classes. Some people do better in a class teaching and having someone to instruct them and guide them. So there are 2-month, 8-week classes at the Osher for mindfulness-based stress reduction based on the teachings of John Kabat-Zinn. And then acupuncture can be a really helpful adjunct as well, especially ear acupuncture. Next session, next slide. So here is one a link to some of the free Osher guided imageries. Next link. And then here are some public classes, the laughter yoga, restorative yoga, they are both free. And then MBSR is a 8-week class that is, it costs about $395 for those who benefit more from having a teacher. Next slide. So there's been also some emerging excitement about neuromodulation. There are lots of studies on neuromodulation for different conditions, including seizures, migraines, and now emerging research on long COVID. There are different ways to do transcutaneous vagal nerve stimulation. You can see the lady on the left, she's using a device on her neck, and there are afferent branches in the neck. So that's one way. And then on the right, there's this little device called Caputron, and you can see there's a little ear clip, and you place that on the left side. Now, even though this is very exciting, and I have had many patients benefit greatly, I think the excitement is this is almost like a passive way to reach a meditative state or to rehab the vagus. The problem is not everybody responds. And I think the reason is we haven't really figured out what are the ideal settings in terms of frequencies, hertz, strength, milliamps, phasic versus monophasic versus biphasic. Every study seems to have a different frequency and hertz. So we really haven't figured out what works best for everyone. And more than likely, it's going to be personalized. Different people respond to different frequencies. And we haven't really figured out how to modify that. There's been some suggestion of tying this to an EEG monitor and seeing, you know, what your brain, how your brainwave responds to different frequencies. But obviously, that's going to be difficult to translate into the clinic. Having said that, there are people who respond greatly to this therapy and others who don't. So we do need more and better research. Next slide. Another very common symptom of long COVID is exercise intolerance. And so I teach the concept of pacing, incorporating periods of rest after any activity, even if it's cooking a meal, not pushing through the fatigue. Patients need to give themselves permission to be where they are in their healing journey. No pain, no gain is a harmful mindset. I tell people to unlearn it. Build strength slowly and patiently before any cardiovascular exercise. And there's a really useful protocol called the Dallas POTS protocol for people who have difficulty standing up or their blood pressure drops and who have POTS. And it's a very intentional, very graduated, very slow, careful rehabilitation program that is free and available for anyone to download. And the link is there. Next slide. Low-dose naltrexone has also been used for long COVID as well as for chronic fatigue. Dr. Bonilla at the Stanford Chronic Fatigue Center has been using this a lot. And again, there are people who respond greatly to this, and then there are non-responders. But it's pretty well tolerated. Next step. I always give these support links for patients. It's very important for patients to seek a support group, as chronic fatigue and long COVID can be quite isolating. Next slide. So what can you do? You can advocate for a basic COVID panel to be incorporated into primary care practice as a first step. These are not difficult labs to obtain in the primary care practice. Patients with long COVID or fatigue can request these labs from their primary care doc. Simple steps such as correcting low iron and vitamin D deficiencies can have a really powerful impact, not on all, but on a significant number of patients. Advocate for more and better research on management of long COVID and chronic fatigue syndrome, one that incorporates women and minorities, since a lot of our data is on 50-year-old men, and chronic fatigue syndrome impacts women predominantly. Request that continuous medical education incorporate management of chronic fatigue and long COVID, and then download and share the Yannick article, which I listed in underneath. It is free to download, and anyone suffering from long COVID can try these supplements to improve their healing journey. Next slide. And that's the end of my talk. Thank you so much for having me here. I'll turn it over
Thank you so much.
to
Sorry.
Lisa McCorkle and Alison Cohen.
Thank you so much, Dr. Cohen. That was extremely informative about healing protocols and an excellent presentation. Appreciate it.
Thank you.
So turn it over to Alison Cohen.
Yeah, are you
And
sharing
Lisa.
your slides or do you want us to be?
Marian, would you be sharing the slides? I think you're muted, sorry.
We can share the slides,
Yeah,
yes.
that would great. Thanks.
And also the links. I think the links that you all have included in your presentations are really valuable. Okay, are we ready for the next presentation?
Ready when you are.
Yes.
Okay.
And I can get started as you're working on pulling it up. So just as a overview, hello, we're going to be talking about epidemiology of long COVID and implications for policy. We can ready. Slideshow present. Great. And so now, yeah, we can go the next. So I'm on the faculty at UCSF. We can go to the next slide. And I'm part of the Patient-Led Research Collaborative, and then I'll be handing it over to Lisa, who's one of the co-founders of the Patient-Led Research Collaborative. All right, so we can go to the next slide. And so I'm an epidemiologist, which means, oh, can you go to the next slide, please? So just to kind of give you an overview, you've already heard some about long COVID, but this is just a sense of, this is a review that folks at Patient-Led Research Collaborative led of, these are all of the different symptoms and organs and possible mechanisms that could be going on with long COVID. So there is still a lot to be learned, but as you can see, it affects pretty much every part of your body, or it has the potential to affect every part of your body, and that there may be several different mechanisms. And what, you know, not all of these mechanisms may apply to everyone, and not everyone experiences all of these symptoms, but this gives you a sense of how broad long COVID can be. Can you go to the next slide? And so I'm an epidemiologist, which means that this is all the stuff that I do. Social epidemiologist, I think about health equity. So just to kind of give you some numbers about how big of an issue long COVID is. So just to be clear, long COVID is usually defined as continuation or development of symptoms 3 months after an initial COVID infection that aren't explained by other reasons. 5% of all Americans are currently experiencing long COVID. Like, that's wild. That's not just people who got infected. That's of every single adult in America, 5% are experiencing long COVID. What we can also look at, if you look at this graph on the right, and this is from Census Household Pulse Survey data that were collected this fall, to Carla Kuon's point, you can see that there are differences by gender. And so it is most common among people who are transgender and among cisgender women. Long COVID is less common among cisgender men. You can also see that there are racial and ethnic disparities in long COVID. And what's important to note too, is that this is based on people who are self-reporting that they have long COVID, based on also racial ethnic disparities and access to healthcare. This may not be telling the full story. And so you can see both ever experienced and currently experienced. And so if you look at currently experienced, for example, 10% of all people who are transgender currently have long COVID. I said it was 5% of all Americans. It's 6.5% of all women. Great, we can go to the next slide. And it's living with long COVID is really, really, really hard. And it can vary in terms of the amount of symptoms that you have and how much of a burden those are in your life. But just like 5% of Americans have long COVID, which is huge when we're like talking about any health issue, 1.5% of all American adults experience significant activity limitations due to long COVID. And again, you see differences by gender. Too. So it's actually about 2% of women and about 1% of men. But it's almost everyone with long COVID is experiencing some activity limitations. It's just that there's this meaningful percent of American adults who are significantly disabled by long COVID. Next slide. And so some of the ways that that significant impact shows up has been labor force. So this is based on estimates of people who had to either reduce the amount of work that they were doing or completely stop working. But this is data from workers' compensation claims. So this is just people who contracted COVID at work. About 20% of people with long COVID weren't able to return to work at all for 1 year. And that's also, you have to go through a lot to get workers' comp. Like, there are a lot of people with long COVID who may not have contracted COVID at work, or who can prove definitively that they contracted COVID at work. So this is a really huge issue. Next slide. And so just to kind of flag, right, that I've talked about how this disproportionately affects women, there's also some symptoms that only apply to women because of reproductive health consequences. And we're just starting to scratch the surface on this. I was involved, this is showing some of the highlights from a literature review that I was involved in about specifically what we know so far about long COVID and female reproductive health, and the answer is not much. Next slide. And so these are just some of the specific research priorities in terms of what we still need to learn to get a better understanding about long COVID and women's reproductive health in particular. Next slide. So basically, in sum, a bunch of people have long COVID and we don't know what to do. So we're 4+ years into this pandemic. There are not yet evidence-based FDA-approved treatments for long COVID. This research is emerging and it is emerging slowly. So people, all of us who have long COVID are trying stuff that's kind of at the edge of science while we wait for others to realize the urgency of this. Also really important to emphasize that everyone is at risk for long COVID. So you can get long COVID from a reinfection, even if you didn't get it from your first infection. You can get long COVID even if you were vaccinated. And then again, it's more prevalent among many of us. Those of us on the call may be more likely to get it, given that it's more prevalent among cisgender women and transgender people of any gender. And it's also important to acknowledge that among people with long COVID who got it maybe on a first infection or on a second infection, getting infected with COVID again has negative health consequences. Everyone's at risk for long COVID because everyone's at risk for getting COVID. And so what do we do? Masking with a high quality, well-fit mask can help reduce your risk of infection. Being outdoors or in high quality ventilated situations can also help reduce your risk of COVID infection. Frankly, being around people without COVID will reduce your risk of COVID infection. And that is very hard to do right now. We're in a crazy high surge and people are not necessarily isolating anymore when they have COVID. Next slide. All right, go ahead, Lisa.
Thanks, Alison. So I'm Lisa McCorkle. I'm one of the co-founders of the Patient-Led Research Collaborative. So I'm going to give a little intro to who we are and then talk about kind of what our needs are and asks are policy-wise as a long COVID community and things that you can do to help. So Patient-Led Research Collaborative is a group of people with lived experience of long COVID and associated conditions. So that includes myalgic encephalomyelitis, chronic fatigue syndrome, or ME/CFS, dysautonomia, different forms of that, including POTS or postural orthostatic tachycardia syndrome. So it's conditions that are commonly diagnosed within long COVID. So we all have the lived experience of having one of these conditions. And we all have a variety of skills that support research or support advocacy. We're over 50 members now across 4 continents. And we met through a support group, through the Body Politic COVID-19 support group in April of 2020. So I got sick with COVID in March of 2020, right before lockdown. With COVID. So I've been, having long COVID since for almost 4 years now. And we ended up doing the first research on long COVID in May of 2020. This was a time when people, public health folks and the government were basically saying, if you get COVID, you'll either get a mild case, recover in a couple of weeks, or it's going to be very serious. You may be hospitalized, you may die. There was not this third option of you're not going to recover. You may develop long-term consequences, despite there being a lot of evidence and for long-term consequences occurring after a viral infection. And so because the people experiencing it, like myself, were being dismissed by our healthcare providers, we weren't seeing answers, this wasn't being discussed, we decided to take things into our own hands, do our own research. And this research was just posted as a Google Doc. It wasn't peer reviewed, but it really demonstrated that this is something that is happening to a lot of people and that COVID is more than just a respiratory illness. We were seeing neurological symptoms, we were seeing systematic symptoms, and more than what was really being talked about in the media and by government. Next slide, please. And so over the last 4 years, we've continued to do research and advocacy So our biggest research study was that we documented over 200 symptoms of long COVID. So they spanned all organ systems and really was a comprehensive look at all of the variety of symptoms that people with long COVID experience. Alison already brought this up, but we co-authored a review on long COVID research in Nature Reviews Microbiology that was published about a year ago. And this has really made a big splash. Last year in 2023, it was the third most viewed research paper in the world. And I think that really demonstrates, one, how many people are impacted by this and how little information is out there. And then two, just how needed that information is, and how desperate people are for information on long COVID. We've consulted on a lot of long COVID studies, including the Recover Initiative, which is the US government's current response, current study, observational study on long COVID. We have had a biomedical research fund where we distributed $5 million in grants to projects that we deemed as patients were of most importance to the patient community. We've created scorecards that evaluate meaningful patient engagement. So one of the, in addition to pushing forward long COVID research, one of the main goals of Patient-Led Research Collaborative is really to demonstrate how important engaging patients in research and in policymaking is, because we are experts in our own experience. And someone who comes in without that lived experience is not going to necessarily design a study in a way that represents the patient experience, or that is even addressing what is most important to a patient. So that's one of our main goals as well. We have a patient-generated hypothesis quarterly publication. So this is where we source hypotheses from the community, from patients and from caregivers, and they draft them up, and we're presenting them to the research community as these are hypotheses that you may want to pursue. It's based in our own lived experience and it's based in our own research. And then we've also done a lot of advocacy. We've provided policy recommendations to Congress, Health and Human Services, CDC, and tried to advocate for more funding for research as well as other support systems. Next slide, please. So one of the main emphases now on really what we need to focus on is what we're calling a long COVID moonshot. And I co-authored an article with UCSF researcher, clinician Michael Peluso in October of last year, calling for a moonshot for long COVID, investing at least $1 billion a year in long COVID research from the NIH. And the point of this is that we are at risk of losing the momentum that we've had the last 4 years into long COVID research. There's been discussions within NIH that there's potentially not going to be any funding next year for long COVID research. And we really need sustained funding so that researchers can make this their career and stay incentivized to be in this field. Next slide, please. And so we put together some examples, and we'll send this out so you have access to the links, but things that you can do in your own community and within our community. So locally supporting mask mandates in healthcare facilities to make healthcare accessible to people with long COVID and other disabled people. I put a few organizations and people that are really leading the way in this that you can follow. For California, at the state level, supporting increased and equitable access to free COVID testing and encourage science-based public health policy decisions. Alison just co-authored a op-ed in the Sacramento Bee about California's 24-hour isolation recommendation and that what implications that's going to have on the state of our public health. So following along with that, engaging with that and really pushing on our leaders to make better policy decisions that are informed in science and equity. At the national level, again, calling for increased research funding. LongCOVIDmoonshot.com has examples of how to do that, and calling for increased funding overall to address the full crisis. And then staying informed, staying up to date. You can follow us on Twitter. There's a few other organizations we suggest, and signing up for mailing lists as well. Next slide, please. And then here's our contact information, and look forward to your questions.
Thank you so much, Dr. Alison Cohen and Lisa McCrockle, on your presentation. That was great data and really makes you feel great about the power of collaboration. So would our speakers have 15 minutes more to stay on so we can get some questions in?
We have a question here that similar to one that I had during the presentations, which were fantastic. I'm so glad that we're recording this, because I'm sure a lot of people are going to want to have this information. What you have shared is just very valuable information. The question that I see here is that looks like there are significant overlaps in both concerns and treatments between persistent Lyme and long COVID. But one is caused by a bacteria and one by a virus. Is this a resulting common issue for body inflammations and immune system reactions? Whoever wants to jump in first. Lisa, you're muted.
Thank you. Yeah, I can jump in here, and then folks feel free to add on. But yeah, so we see a lot of infection-associated chronic conditions like persistent Lyme disease with long COVID, ME/CFS. There's a lot of times it's a kind of a hit to the system that sparks inflammation and then drives a lot of these mechanisms forward. And so that's kind of the power of studying these conditions together and doing cross-illness research, because there's so many commonalities in symptoms, potential treatments. For example, dysautonomia, which is really common amongst people with long COVID, is something that can be triggered by an infection. It can be triggered by I'm going to lose the name. What's it called when you hit your head? Like a TBI, a traumatic brain injury, or concussion. It can be triggered by, a bunch of things that kind of trigger inflammation and then trigger this like response of your nervous system. So short answer is yes, it is a common issue, and I think is a important indicator of why we need to study these conditions together and see what treatments, if something works for chronic Lyme, could it work for long COVID? And if not, maybe that's a key to the different mechanisms at play.
Thank you, Lisa. So I had a question for Wendy Adams, actually. I heard something about a Lyme moonshot also. Could you speak a little bit about that?
Sure. I mean, I think we all have been talking about getting more funding for years. I think there is a realization that we need more funding for Lyme and tick-borne infections. I think the question has always been, how do we get that funding? And also, where does it go once we get it? A lot of the issues arise from not studying the right things. The NIH is not set up to test innovative science. They are set up to support basic research. And the distance from basic research to helping patients is long and fraught. And certainly Lyme disease has been has lived through that. There's about, it's less than 5% of the NIH budget in Lyme disease that goes to study therapeutics. And so it's not just how much we get, we need more, there's no doubt. It's what it's spent on. Just studying pathogenesis is not sufficient to bring better diagnostics and treatments to patients. And so it's really, you need both in concert. And that's, I think, one of the places where, patient-led research collaborative and Bay Area Lyme and other organizations can work to influence what money is being spent on, and the importance also of patient-led research funding. We fund things that the NIH won't fund and will tell us they won't fund because of the way that system is set up. And so we really need both. We need patient-led research funding, and we also need NIH. But I think we need to make sure that NIH is spending money on the things that have the most chance to help patients in the near term.
That makes sense. Thank you. And I think Bonnie Crater, the founder of Center for Lyme Action, is in the audience, and she just put a link in about it in chat.
Yeah.
So I had a question from Professor Dr. Alison Cohen also. Would you speak to California's 24-hour isolation recommendation and its impact on long COVID?
Sure. So, well, you can go to Sacramento Bee and read the whole thing, but yeah, basically what we're saying is, look, we actually framed it as health equity. They just lifted up the long COVID for the headline too, but people are infectious and contagious for way more than one day. And so if folks are going out into the world unmasked with active COVID, they are going to give a lot more people COVID. And so just by the virtue of having more COVID infections, there will be more long COVID. There's also emerging research that suggests that having the time to be able to rest and recuperate during an acute infection can be helpful. The challenge is that we don't have adequate paid leave. So that is a luxury rather than something that people are often have a right to, and like that they don't necessarily have a right to or feel entitled to that or can afford to if their employer is not providing any paid leave. And so that's in a nutshell, what's going on. What I will also say is that, like, for me, I got COVID that gave me long COVID through a well-fit healthcare N95. So for me, I know that one-way masking is insufficient. And so I am reliant on other people to also mask. In 2024, no one else is masking. Like, some people are masking and anytime, like, but very few. So it's not officially no, but it rounds to no people are masking. Very few people are masking. And so that's why it goes into like this point too about places not being accessible because of prioritizing people with COVID, with active COVID, wanting to do whatever they want over prioritizing those of us who are more vulnerable.
Thank you.
A question related to that from our audience. Is it possible for the symptoms of chronic Lyme or long COVID to resolve completely? And how would that
I'll
happen?
take that for Lyme disease. Based on my Lyme data, about 50% of patients are much better or somewhat better, and those are the people, and about the same number of those took antibiotics, right? I will say that I had chronic Lyme and I am 100% better. I was on treatment for a number of years and I took a lot of antibiotics and a lot of other things, a lot of herbs, a lot of, so I definitely took the Dr. Kuon method, right? And through the help of Lyme specialists. So it was both supplementary towards, taking certain supplements, and it was also antibacterial, large amounts of antibacterials, rotating different types. I will say that I am one of the minority, I think, that probably get 100% better. So I'm very fortunate. That's why I do what I do.
For long COVID, we're seeing there's one study that shows that only about 8% of people who had long COVID at 3 months were recovered by 2 years. And so it's small there, but there's varying studies that show different things. But what we're also seeing is that people who thought that they recovered, it seems like they're actually just potentially in remission. And when they, maybe get COVID again or get another illness or have another one of those hits to their system that sparks that inflammation, they get sick again. So unfortunately, I don't even like using the word recover at this point, because it seems like it's more that people who do see improvements and get back to that 100% that they were before they got sick might just actually just be in remission.
I'd also just add that some of the people who are currently being classified as long COVID, some of them were in a hospital, in an ICU for an extended period of time and recovering from that experience, versus those of us who had milder cases that did not require hospitalization. And those can have very different trajectories. And so in fact, it seems like actually evidence is suggesting that like some of the folks who were hospitalized and then had to just recover from hospitalization are maybe having more positive recovery trajectories than folks who maybe they get to a point of remission. So I think just keeping that in mind, that eventually we'll probably separate out those groups may become separate in the future, but that they're both, those can be very different trajectories of health.
I think, can I just add something too? I think it's really
Sure.
interesting. Something that long COVID has really brought out are the number of different factors that are making people sick, right? And this elucidation of the different problems that can be arising. I think we've known the same in Lyme and tick-borne diseases for a while. If you have a neurological sequelae where you are demyelinating your myelin sheaths, you basically are getting multiple sclerosis or ALS-like presentation. Those are much harder to get better from. And so I think it's like within each of these infection-associated chronic illnesses are 10 different illnesses, right? And we don't have the data, certainly in Lyme disease. I think we're on a better path than long COVID just because of the numbers, but we don't know what those individual sectors are and how best to treat each individual one.
So is that why we have long COVID, but we don't have long flu?
Well, we do. It's just called MECFS. It's kind of been bucketed into, another phrase of like several infections can cause MECFS, which COVID can also cause MECFS, and now is under the umbrella of long COVID.
Okay. And there's a question here for Lisa and Professor Alison. Could you please describe the patient-led phrase more? How can people watching this presentation with those chronic conditions assist in that patient-led?
Sure. So patient-led is really what we are trying to do is have basically a paradigm shift in how research is done. And instead of researchers who don't have lived experience pursuing hypotheses that they want to pursue without consulting patients, instead of that being kind of how research is done, we want to demonstrate the importance of patients leading research and really using our expertise, because we have that lived experience, to inform what hypotheses we need to go after. So I think maybe our scorecards, which I'll put a link to in the chat, do a good job at kind of showing the scale of collaboration to like what we're actually looking for a patient-led collaboration. There's some researchers who want to engage with patients, but do it in kind of a tokenizing way. So maybe they will have a patient on, an advisory team, but then don't really listen to that patient when they're describing their experience or giving feedback, but kind of use it as a check the box type of thing. And what we really want to see more of is, we need the researchers. We're not saying that just as patients, we can do all of the research on our own. We need biologists, we need people who are trained in this. Often those people can be patients themselves too, but really having more of a partnership and having patients be the one to be like, this hypothesis is really important to us because it affects my day-to-day life more than maybe a hypothesis that like some random researcher wants to pursue. I probably could have done a better job at explaining that, but it's really just putting the patients at the driver's seat of research, since we're the ones experiencing the condition and we're the ones who, the researchers ideally are like doing research for. So we should kind of have a say in that.
Just to add, like my background pre-pandemic too is doing community-based participatory research. And so it's acknowledging that people who are living this day to day have relevant expertise, that you don't need a PhD to be able to have relevant insights into a specific health issue. But that those of us, we can all be working together to try to develop the most rigorous and the most relevant studies to be done to advance knowledge on a given health condition.
Thank you. So I have a question for Dr. Kuon and Wendy Adams. So what do we do about the medical community? Because a lot of times people go to doctors and they are told that there's no such thing as long COVID. Or they go to doctors and they're told there's no such thing as chronic Lyme. That's very demoralizing for a lot of patients who read about it, they've done their own research, and they found that these conditions do exist. So how can we change that mindset with the medical professionals?
Yeah, I advocate for there being courses and classes, and most physicians have to get a certain amount of hours of CME, continuous medical education, in order to be able to renew their license. And a few years back during the opioid epidemic, it was a requirement that you get a certain number of hours of training on opioid dependency and opioid-related diseases and how to manage pain. I feel like it should be a requirement that physicians get, 5 hours a year of training on fatigue-producing symptoms like chronic Lyme or long COVID, so that there's a little bit more education in the community. There's plenty of evidence now to say, yes, long COVID is a syndrome. Chronic fatigue syndrome is a syndrome, but if physicians don't know about it, the default will be to tell the patients that they're just making it up or it's factitious disorder, to just shrug their shoulders and deny that it exists, right? So I do think that primary care physicians are going to be the very first people that are going to be approached with these symptoms. And if they don't know about chronic Lyme or about long COVID, then they won't be able to help their patients. And like you saw in my handout, many primary care physicians may not be comfortable prescribing supplements, for example, but they can check labs. They can check some basic labs and start repleting vitamin deficiencies. That's low-hanging fruit that does not take a specialist in long COVID or chronic fatigue syndrome to do. So there's a lot that physicians can do. And I think advocating for CME to incorporate, to require 4 or 5 hours of training in these conditions would be a good first step. And then, of course, asking them to run these labs in a way. I think sometimes patients need to learn how to advocate for themselves to their primary care doctors and ask for that ferritin. I guarantee you it will not be ordered unless you ask for it. So patient education, so that educated patients can be empowered to advocate for themselves, to their primary care doctors, I think can also be very powerful.
Thank you.
So I think this is a key question, Raina. It is so important, and the lack of basic training in Lyme disease is astonishing in the medical education system at universities. They get like a few hours of Lyme disease education, which is why they don't know how to recognize a rash, and they don't know that it is understood and agreed upon that people do have persistent symptoms. We can have discussions about what the causes are of those symptoms, but Interestingly enough, it's since the 90s that the government has understood that there are chronic symptoms. It was actually called by CDC chronic Lyme. Everybody called it chronic Lyme. And so this is more of a recent thing where people have disputed what the cause is. I think I'm going to bring it back to diagnostics, because if we have a diagnostic that can show which people are still infected, which people are infected initially, and then which people go on to still be infected despite the fact that they've been treated with 2 weeks of antibiotics, then I think that will go a long way to proving to doctors that their patients are still sick. If many of the people with chronic or persistent Lyme disease never get an early diagnosis. Some do, but most don't. And that is a huge problem. The doctors then look at symptoms and say, well, you didn't really have Lyme to begin with. So this can't be chronic Lyme because you never had Lyme. And so if we have a better way to tell doctors when somebody has it and when they don't anymore, that being the infection, then we can expect better treatment. I will say that this is a huge problem. It's a disagreement among the CDC and the patient community, and it was one of the requirements in the congressional reports that were delivered. That was, you need better continuing medical education, and not only that, that medical education has to be agreed upon by the different stakeholders, because there is a variety of different data, and it's not perfectly similar. Some of it is contradictory, right? So you need a responsible way to present that to doctors.
Thank you. Marianne, do you have any questions? I think Dr. Carla Kuon actually has to leave.
Okay, I understand, and Dr. Cohen has actually had to leave. I would just like to thank all of our presenters for the tremendous amount of information they have shared, and our participants in the audience for their questions and for coming to this presentation. We will post the recording and send the link out to everyone who has registered for the event. And I don't think you'll miss anything. And if if I have the presentations, I will include those with the thank you for attending this event. Thanks again, and have a wonderful week.
Thank you, Marianne.
Thank you so much.
Thank you. Bye.
Bye-bye.